Aloha, I'm Eva Andrade. I am the president and CEO of Hawaii Family Forum. And on today's episode of Faith and Politics, we're going to look at the 2019 assisted suicide numbers that was recently released by the Hawaii State Department of Health. So let's chat about that. Aloha, everybody. I'm Eva Andrade. I'm the president and CEO of Hawaii Family Forum. And today we are going to talk about a newly released report from the Department of Health on assisted suicide in Hawaii. And in order for us to have an eloquent and detailed conversation about that, I've invited someone I know for a long time. I've worked with her a long time, who has a background in the medical profession. She is a registered nurse, and I'd like to welcome to the show today Joy Yadao. Welcome, Joy.
Thank you so much, Eva. Thank you for allowing me to participate in this. It's quite a pleasure.
Not a problem. I want my viewers to love you as much as I do. So why don't you give a little bit of background of who you are, because you are a local girl, and where you come from, and maybe how you got to where we are today to talking about assisted suicide.
Sure. Yes, like you said, I'm a local girl, raised here, went to school here, decided to go to nursing school. I am a registered nurse, and I've had quite a bit of experience in all different kinds of nursing: hospital nursing, home nursing, case management. I've worked for, wonderful organizations here locally, large hospital systems, and as well as for insurance companies, doing some case management on very difficult cases. And while doing that, actually, I got involved with hospice care and saw, firsthand how we can really change a person's life, and how they, view their health, and how they can utilize the health system a little bit better by using their hospice benefits. And I got to learn about that. Eventually went on to work at hospice. Started out just being a registered nurse, not really sure what I believed in as far as hospice goes. And at the end of the story, I became the executive director of St. Francis Hospice after managing the facility care as well as the home hospice care, and looking at all, different aspects, all walks of life, people of every faith and ethnicity and cultural values, and helping them come to terms with their terminal condition and with their death, and allowing that to happen in a peaceful way with symptoms managed. It just is so gratifying. People said, "Isn't that a sad job to have?" And yes, my patients were dying, but it's very, very gratifying to help someone and to help a whole family get through that most difficult time in their lives. And it can be done. The amount of suffering that people experience because they don't know what's happening, and they can't anticipate, and they're too sick to learn or to help their families get through it, knowing that they have a whole team helping them, was just so relieving to them. You could see the physical relief of people, and knowing that we're going to take care of them and their symptoms, and they don't have to be afraid to die. And for those that had spiritual needs or issues, there was help available for them to reconcile everything before they got to that point. It was just absolutely fascinating to me, and such an enjoyable, fulfilling part of my career. I then left hospice for a while, did advocacy work, as you know, at the Capitol, advocating for the sisters and for the values of a faith-based, organization, nonprofit organization, and how we were going to be able to survive in difficult times. And so I learned a lot about law, and about how it's made, and how to advocate for good decision-making in the law. I've also worked for Medicare on some grant projects and trying to improve the quality of care in our community here in Hawaii. And I'm currently involved in infection control, which is the hot topic of the day, and everyone is certainly concerned about COVID-19. But even for end-of-life care practitioners and hospice and palliative care folks, COVID-19 has made a big impact. And for those that are facing death because of COVID-19 or because of the symptoms that they already have from comorbidities, it's serious, times. And it's time to look at how we do advanced care planning, how we assist people in getting the right kind of care. And that is a dedication that I continue, no matter what type of job I may have or what little niche I'm in. The theme is we have to improve the quality of care for people all the way until their natural death. We have to help them and be transparent about what is available, so that they can make decisions based on their faith, based on their family values, and do what's right for them. But I am very, very pro-life. And for me, working towards the geriatric population, pro-life is more about the quality of that end-of-life portion. How do we get through? We're all going to die. And so how are we going to get through that in the way that we believe God wants us to, and that we can share with others what that really means and be honest about the situation. And I feel that there is an awful lot of dishonesty going on in this business, as I'm sure we're going to talk about today.
Yes. In fact, before we jump into the report, which you and I, what we want to be honest right before we start, is that all we're going to do is give the numbers and reports as it was given in this current report. So we're going to share with the community that wants to know more about this everything that we can that's going to be a factual base on this report. But of course, we're going to be talking about it, as Joy mentioned, from people that know what it's like to be at the Capitol, to have these discussions with legislators. But before we jump into that, Joy, you want to tell everybody what high school you graduated from? What school you in grad?
What school you in grad? Okay, well, as you know, I went to Star of the Sea up till 8th grade. And then I begged and begged my family not to send me to all-girls high school. So my original idea of becoming a nun was not going to be happening. We knew that early on. So I got into Hawaii Baptist Academy. The high school was fairly new, the new campus in Nu'uanu. It was the first year that it was open. So I went to HBA. So it's funny, I was a non-Catholic in a Catholic school, and then I went to a Baptist school, and I wasn't a Baptist either. But I got a very good perspective and look. I grew up Lutheran, and looking at, the way different people do different things, I think it really helped me to form, friendships along the way. I went to KCC for nursing school. I still believe that KCC associate degree grad nurses are the best there is, because it was a hard knock school. We really got put through the ringer and came out to be good nurses. I'm married my high school sweetheart, and we have 3 kids that are, I won't say what ages they are now because, I would have had to have been 5 when I had them. But I also have 5 grandchildren, 2 of them in high school. So it's been a wonderful, I love Hawaii. I love the people here of Hawaii. I've traveled quite a bit in the Pacific, both the South Pacific as well as the Western Pacific, all of the islands in Micronesia, spent some time in Palau, Guam, Saipan, Samoa, just absolutely wonderful people that make up Hawaii. And I'm glad to have raised my family here. I'm proud of it. I'm proud of the way that we do things here. It's not perfect, but it's better than anywhere else in the world. And it's that caring for the actual people of Hawaii. When I worked at HMSA, we worked with large populations, and there's a lot of value in doing that. But I traded that for hospice, where I was working with people one-on-one. And that's where the rubber meets the road. We have to do the best that we can for each individual as they go through trying times.
Yeah.
I like to speak out about this. I enjoy that, I'm part of HPAC, our partnership for appropriate compassionate care. Long before other groups were doing this, we were making sure that people knew that it was not appropriate to end your life prematurely.
Yes, and I think that that's what we want to do right now, viewers, is to really jump in to this current report that was released. And this report was released on July 1st, 2020, and it covers the period of January 1st, 2019, all the way up to December 31st, 2019. And what we're going to do is just kind of dive into some of this. But before we do that, we want to back up just a little bit so that viewers will understand how we got to assisted suicide being legal in the state of Hawaii. And it actually all began in 1998 under the leadership of Governor Cayetano at the time. He established a blue ribbon panel on death and dying, and he asked them to come up with their recommendations for assisted suicide and euthanasia. And what a lot of people don't know is when that report was issued in 1998, they actually had two recommendations, not only to allow assisted suicide, but to also allow direct euthanasia, which was actually very interesting. And as a lot of our viewers know, Hawaii is always on the cutting edge on these kind of issues. We were first on abortion, and assisted suicide was definitely there on the docket to be first in Hawaii because of our very liberal legislature. And not just that, it's the way that Hawaii looks at compassion for people. And I think it seemed to be a very easy fit with the way that, as Joy mentioned, her growing up here and the way that we do things here in Hawaii is always very different than the mainland, and it seemed to be an easy fit. So the first assisted suicide bill actually came up in 1999. And in 1998, Hawaii Family Forum partnered with the Hawaii Medical Association to create this organization that Joy just mentioned, the Hawaii's Partnership for Appropriate and Compassionate Care. And there were two reasons for forming this coalition. The first one was to stop any attempt to legalize assisted suicide in the state of Hawaii. The second reason was to promote access to palliative care and hospice. And a lot of people do not know that not only were we fighting against assisted suicide, we were also doing everything we can to increase access to palliative care. Now, before we jump, I know that there are people listening to this and they just heard a whole bunch of stuff and they don't know what stuff means. So, Joy, help us understand, first of all, the difference between assisted suicide and direct euthanasia, just so that we can kind of understand the terminology.
Sure. Euthanasia is, the extreme in this spectrum. Euthanasia is when someone, probably a physician, but it could be other people, depending on what laws are available, but it's when someone takes an active part in causing the death of another person. Not homicide, not manslaughter, but actually injects a medication into someone's veins or performs an act of maybe suffocation or some other means to relieve someone of their life in a situation where the person has asked for it and the quality of life is somehow determined to be poor. So if they used to call it mercy killing, so people might understand that kind of aspect of mercy killing. It's not an intent because you're angry at the person, it's an intent because you're relieving them of their life suffering. It's gotten to the point in some countries in Europe where even just I could go into the doctor's office and say, I'm tired of living. I'm kind of done. I did everything I set out to accomplish, or I'm just so miserable in my life, I don't even want to live this life anymore. I'm done. And they would kill me. They would relieve me of my life. That's euthanasia. Someone has to do the act for you. So then that's pretty extreme. So you move kind of upstream into assisted suicide, what we call assisted suicide. It means someone has to assist. Someone, like a doctor, has to write you a prescription or give you the medication and put it on the table, but they can't make you take it. They can't do it for you or give it to you. All they're doing is assisting you in your goals to end your life. So you go fill your prescription, and whenever you take it is whenever you take it. The doctor no longer has any, reason to be involved with that. It's up to you. So therefore, I consider it suicide. I feel that that is the right term to use because it is you taking your own life. But you need the assistance of a physician to determine, in accordance with our laws, you need to determine that you are actually suffering a terminal illness, meaning you're dying anyway. And this would just be to speed things up or to take that life before the natural ending of your life. So that's assisted suicide. And I guess in some instances it could be assisted by anyone. In our laws, it's the physician that would have to write that prescription.
So when Hawaii's Partnership for Appropriate and Compassionate Care was established, obviously it was a group of physicians, it was a group of doctors and lawyers and people in the community that were nurses that were opposed to assisted suicide. And because of this strong and the disability community was strongly and still is strongly opposed to this, we were able to hold assisted suicide back for a number of years, and it wasn't until 2018 that assisted suicide was finally legalized in the state of Hawaii. And in order for an individual to qualify for assisted suicide, they have to meet certain eligibility criteria. And so we're going to take a very quick break, so don't run away. We'll be right back after this brief message. Aloha, I'm Eva Andrade. I'm the president of Hawaii Family Forum, and we've been serving Hawaii's faith-based community since 1998. What we do is we provide research and education to the faith-based community to help them understand what's happening at the state capitol and what's happening on the issues that affect the families here in Hawaii. If you would like more information, please visit us on the web. But in the meantime, know that Micah 6:8 says that the Lord requires of us to do justice, to love mercy, and to walk humbly with your God. And we can help you do that, not only to raise your voice the way that the Lord calls us to raise our voice, but to understand the issues on a scriptural basis. And we'll tell you how you can learn more about what's affecting Hawaii's families. Mahalo. So they have to get a mental health evaluation, but they can get that mental health evaluation done via telehealth, which we may be able to discuss a little bit about that as well. And they have to be a mentally capable individual that they're able to make their own informed decision. Now, Joy, I think that what I'd like you to do is kind of talk a little bit about this informed decision, this decision-making capability. I mean, what does that mean? Who falls into that category?
There are different thoughts about that, of course. Doctors evaluate people. There may be some other disciplines that can evaluate using a mental status exam to see if someone can make proper decisions, that they are, oriented to their surroundings, that they know who they are, they know what kind of disease process they're going through, and have a sound reason as to why they want to do this. They're screened for depression, because depression can certainly cloud the opinion and decision-making capacity. But to have mental capacity, technically it is a physician, a psychiatrist that is the only one who can really say whether or not someone has mental capacity in a legal sense they can make, all their medical decisions themselves.
And I
So
think
someone with dementia would not qualify.
And part of your concern, though, I remember during the hearings, was that they allow social workers to make that determination as well in Hawaii law, correct?
Right. So there are, in the mental health area, it's not just the psychiatrist that, helps all of us. There are counselors of all different kinds. There are psychologists, but oftentimes in a psychiatric practice, you'll have licensed clinical social workers who are trained in, psychiatric care that would do some of this process, similar to how nurses may work in a hospital. The social workers assist the psychiatrists. They don't prescribe medicine, but they make assessments. I don't know that all social workers are trained in end-of-life decision-making. I think that's kind of a specialty. And also, if we're doing this by telehealth, that's a huge concern. We're doing everything now but by telehealth, and we're doing this interview that we would normally have in person. We're doing it on this format.
Right.
I can't possibly tell by just looking at you whether or not, and asking you questions, whether or not you are being coerced, whether you are completely in your sound mind. How will I make that full assessment? I think it's very questionable. A licensed clinical social worker is an appropriate clinician for the job, but I think it's a stretch to expect them to make this kind of capacity decision by telehealth.
Yeah, I really want our viewers to think about that, because many viewers have already experienced telehealth now during this COVID-19. I myself have had telehealth visits with my doc, and it's different. I mean, we want to make a couple of things clear. First of all, we are not condemning social workers, okay? So we're not making any claims that social workers shouldn't be part of this decision making. What we're saying is we want to make sure that when someone is having to face these end-of-life decisions, because that's what we're talking about. We're talking about people who have been, they're facing a diagnosis that ultimately is going to end in their death, and they know this. If you're experiencing the emotions that you're feeling when you get that diagnosis, and you're trying to deal with it via telehealth, there may be some concerns. Is the doctor picking up on all of these fears that you might be having? Because you might be a really good person at hiding your fears. Some people don't show emotions very well, and they always come across being, well on top of everything. But their close friends know by the way their eyebrow is twitching, or the way that their mouth is so stiff that they're very stressed. These are things that only trained individuals, and even physicians themselves, admit that they don't always know when somebody's experiencing mental health issues. They're not trained for that. Physicians have expertise. They go to school to get more in-depth training on certain things. That's why when you have a foot problem, you go to a podiatrist and you don't go to an eye doctor, right? I mean, there are specialties. And so that is the concern that we want to bring up. Not that we're questioning any particular individual's ability to do their job. So we want to make that really clear.
No, and a physician is someone who is trained to save lives. There are many wonderful, caring practitioners of all kinds that are providing, health care in this country and in this state and just in my neighborhood. I see it all every day. But this is a particular specialty, and knowing what kinds of things might be going through your head as you are facing a less than 6-month prognosis is important. I may not show you, I came professional, I'm going to talk to you on my telehealth thing, and I'm not showing my vulnerability and my fears about things that happened in my past, and will I be, punished for that, or maybe my daughter is sitting right here to the right of me, and I know that she wants me to speed things along a bit, and she's convincing me to do this. And so even though I have ambivalence, I'm saying, oh yes, I believe that I want to do this. It's hard to judge coercion and things of the inner workings of the mind just on a video screen.
Yeah, we know this is true because domestic violence has been going on for years and years and years. In fact, I just recently did an interview, for those of you that know, with Reverend Al Miles from Queens Medical Center, who talked about intimate partner violence. And even people that are trained to look for these things don't always see the signs. So again, we're not trying to make a blanket claim here. We're just talking about facts. We just want to paint this picture with very clear strokes so that we know what we're talking about. So as we've discussed the criteria, so now we're moving to people that have met that criteria. And in 2019, they availed themselves of it. So let's, we're going to go through a couple of numbers. I'm going to take a very quick break, and then we're going to come back to close this program out. Because as always, the time is already nipping away. But so let's talk about some of these numbers, Joy, and I really want to get your manao on this, because again, this is your area of expertise. This is what you do. So the number of qualified patients that actually fit all of that criteria in 2019 was 30. There were 30 individuals that fit that criteria. Now, 23 known qualified patients that died from the prescription written, 23. Okay? The cause of death for these 30 patients had a wide range of issues, but most of them were cancer related. There was everything from Parkinson's to one who had ALS. So again, we're talking 30 prescriptions that were written. And now, of the 30 prescriptions that were written, 19 of them died while enrolled in hospice and had access to this palliative care medication that you're talking about. But only 15 of the 30 actually died, right? There were 13 physicians who participated in this, and we want to make it clear 12 of those doctors are on Oahu. One is from the Big Island. So Maui and Kauai were not included in this, although one doctor did step up, I believe, for 2020 on the neighbor islands. So Joy, let's drill this down a little bit. But I think as we were thinking about this, 30 people, we are talking about 30 people who qualified, right? I want to be really clear that the report says, and I quote from the report, community inquiries to the Department of Health are minimal via email or phone call and are responded to promptly. Now that's a direct quote, page 4 of their report, which means that they're not being inundated with a lot of community questions about assisted suicide. But the reason I bring that up is because the report also states, and I quote, the status of 3 qualified patients who received aid in dying medication is unknown. And they go on to say an unknown patient status occurs when a follow-up form is not received by the department. So I'm concerned, Joy, and of course we're going to break down a lot of this stuff, but I'm concerned that there were 3 patients who availed themselves of this. They qualified, but there's unknown information. The Department of Health is making very clear that they're not being inundated by a lot of requests. Now we know that they're busy with COVID-19. We want to make that really clear. Nobody's saying that they're sitting around doing nothing, twiddling their thumbs. But does it concern you, Joy, that there are 3 individuals who were given a prescription, but we know nothing about them and there was no follow-up?
That's very concerning. That's alarming, actually. And that is 10% of the total amount of people that qualified for this. We're talking very small numbers, first of all, which, it just amazes me that we have, we've had to fight a whole movement and, and enact laws for 30 people a year. But besides that, okay, these are 30 legitimate people. What happened to those 3? And during 2019, we were not battling COVID-19. So, in this current year, I can understand why the Department of Health might be, very busy. But in 2019, they had, I assume, a dedicated resource to answering the phone and, taking care of the concerns and all the paperwork. And they had 30 cases for the year. So I think it would not be that difficult, in my mind anyway, to follow up with those 3 people. The Department of Health has the ability to, get information from physicians. They are allowed legally to have medical information on people, and even follow up with the individual themselves and call the family and say what's going on. We need to control a little bit more when we are prescribing and dispensing lethal doses of drugs to people, and we don't follow up and we don't know what happened to them. That's not right. That's just not right.
And I think you've also been concerned that with the number, so we're talking 30 people and then you have 23 that actually pass, right? What is anybody looking into the medication that has been prescribed for those patients that may have died naturally and without the medication? Or maybe those that just chose, they had it, but they chose not to take it or whatever. I mean, is there any follow-up that we know about to find out about that medication?
For the people that were on hospice, I would assume there's some documentation about the fact that they had a medication in the home. But the hospice doesn't provide it, so they're not obligated to keep track of it or watch it or anything. No one is in this law, other than the individual who was, oriented and had capacity. Those drugs could be anywhere right now. Out of the 30 that were qualified, 15 used the medication. Where are the other 15? 23 died of the 30. Okay, 7 are still living then. What's going on with that? Maybe they weren't terminally ill. Why do they have these strong medications in their house? Is that a public health issue? Is that a danger? I think all of these little details are not being looked at because they weren't included in the law. We're only getting very basic information, and obviously 10% they're not following up on.
Yeah, and let's make this clear. We're talking about people that are dead. We're not talking about things that are up in the air and somebody's thinking might be, could be, should be. These are people that are actually dead. And so we have a right as a community to question, to make sure that everything's being done above board. We're not questioning whether the person wanted to die and all that, because they have to go through many steps to be, to avail
Right,
themselves.
that's between them and their physician.
That's between them. But what we're saying is that these numbers that were provided and the report, the Department of Health themselves in this report agree with you, Joy, because on page 7 of their report, they list their things that they recognize because they opened up meetings to have meetings with physicians and all that to find out how this law is working. And their final bullet point says they recognize concerns about medication disposal and the need for information about its process. So we're not just saying this because you and I happen to be opposed to this. We're being very concerned that if somebody's life is being lost, that proper documentation is being taken seriously, and we're very,
right.
very
we want to
concerned.
strive for transparency in government.
Yes.
Whether you're for this law or opposed to this law, whether it works for you or not, that's not what we're saying. We're saying we need more transparency. We need to make sure that the law is being applied as written.
We hope you enjoyed part 1 of this interview with Joy Yadao. Come back next week for part 2. Thanks for tuning in. Hey, if you liked the video today, don't forget to like, share, and subscribe so you will know every time we upload a new video. Mahalo!